Welcome, friends. Welcome, everyone. This is Dr. Sharad Jaitly from New York on your favorite website, MuniMeterHealth.com, which is your website to teach and educate everyone on human heart and its illnesses. As we go forwards, we are using this new software, as you see, that has been incorporated in the past several videos. I'm excited about it, and I'm using it now freely on Facebook and YouTube. Those are our two channels. Hope you are on either of them or on both of them preferably. And thank you again for your enthusiastic support and viewership that's growing tremendously. I appreciate that so much in my cause of spreading this word about human heart and its illnesses across the globe. So without any further ado, and let's delve into the state of the matter, as I always say, or the matter of the heart. And today we're going to be discussing the cardiovascular predictors of a perioperative event. So cardiovascular predictors, what are they? And how do they predict a perioperative event will be the question that will be hopefully answered at the end of this little video session. So we classify them under major, intermediate, and minor, if you will. So the major criteria, obviously, for cardiovascular prediction for perioperative event. Then you have an intermediate, what are the cardiovascular predictors, and then you have the minor ones, okay? So these are the three major groups, if you will. And in the three major, we'll be talking about the following way. Well, one of the first things that immediately comes into your mind is your unstable angina or an acute MI. If someone has had an unstable angina, acute MI within the 6 weeks period, then that is considered as obviously an event which is going to be a high major predictor of perioperative event from cardiovascular standpoint. Other issues are like uncontrolled hypertension, if you will. So uncontrolled hypertension, uncontrolled diabetes, these are some of the areas where you'll see that the A1C, for instance, is more than 11. Hypertension is 220 over 150. So these are extremely, extremely high cardiovascular predictors for a perioperative event. So they need to be immediately controlled, and not that they can be controlled, but they must be controlled before an elective surgery is planned. Remember, anybody who's going for prostatic surgery is an elective surgery. Anybody going for bilateral hip replacement is an elective surgery. Somebody's going for a lung resection. Somebody's going for thoracic surgery or cardiothoracic surgery also could be planned and could be elective and could be delayed for a few days to up to a week till all these things can be stabilized. So it's very crucial that we look at unstable angina and acute MI, understand their symptoms, understand the compliance. Now, some of these things may not be included within the textbooks, but remember, somebody who's had an acute MI and it's been past 6 weeks, but what if this patient is not taking antithrombotic therapy and there's non-compliance? So that immediately moves that patient from intermediate to a major category, even though it was past 6 weeks. So remember, unstable angina, acute MI past 6 weeks obviously falls into an intermediate category because you have established CAD here in these individuals. Therefore, they are intermediate category. But do take into account that these patients are compliant. If they're non-compliant, then automatically I move them into major category. Remember that. It's the same rule applies here. If the hypertension and the diabetes, they're controlled, they fall into intermediate category because until then, until they're uncontrolled, they are obviously in a major category for cardiovascular predictions. But hypertension, diabetes, once they're controlled, they fall into intermediate category. Similarly, let's understand what are the other things like decompensated heart failure. Now, that's one of the issues which has constantly invaded our minds, if you will. So what is considered as decompensated heart failure? Many times the S3 gallop never disappears in a heart failure patient. Will that be considered as... So again, you have to look at so many parameters. You have to look at the pedal edema, which has been growing over a period of time. We have to understand that there's a non-compliance there, the weight gain, for instance, or the ability to walk or exercise less than 6 minutes on a flat surface. That is considered as a very, very high risk category, and therefore it should be considered as cardiovascular prediction for a high perioperative event incidence. So, and then you look at the ventricular arrhythmias like VTACs or triplets on Holter or otherwise, and have they been addressed? Or there are SVTs which have not been controlled, or rapid AF that has not been controlled yet. So these are some of the arrhythmias that one has to take into account. Do not forget the high-grade AV block. Remember, the high-grade AV block also falls into this major category. Yeah, so all of these will have to be attended to. Now, just like an acute MI or an uncontrolled hypertension can be treated, I'm not saying that these can be treated either. They can be treated, but have they received any devices? Did they receive an ICD placement? Did they receive a pacemaker? Was there an ICD placement done in these individuals? So all of that will be taken into account, and these devices then in that form, if they are present, then they should be placed into an intermediate category. Now, if these patients have devices, but they've not been interrogated for years, now that makes them into a major category. So try to ascertain. So there's a whole bunch of issues that one has to ask before you can clear this patient and say, look, you have a very low probability of a perioperative event in this individual. Maybe patient could be cleared for surgery. So again, in a very short video, in a very short manner, I'm trying to discuss out the cardiovascular predictors in a perioperative setting by analyzing these some parameters here. Minor category, well, if somebody talks about LVH pattern on an EKG, for instance, or say even a controlled hypertension, that could be considered as somebody has a pressure 150/90 but is taking meds. That could be a minor category. Somebody has diabetes which is well controlled and the A1C is 7. Okay, so that still is a minor control. Some electrolyte abnormalities yet can be there which can be corrected overnight, like a calcium, a potassium, etc. That could be corrected overnight as long as it's corrected. So there could be a minor criteria. Somebody who has left bundle. Now, left bundle and abnormality on an EKG could be sometimes very conciliatory. I hate to use that word. But left bundle could be very, very concealing because it doesn't tell you much about the unstable angina. Doesn't tell you much about if a patient has had a recent MI, especially in an elderly group. So remember, age is another minor criteria, but this is non-modifiable, obviously. You can't reverse the age now. So say a person, a 50-year-old going for the same prostatic surgery versus a 75-year-old male who's going for same surgery under the same events has a higher risk, but it still is a minor risk here as opposed to that 50-year-old individual. Okay, so just remind yourself. Left bundle branch, remember, as I said, it's an abnormal. I consider that as an intermediate risk because you could be misled because somebody may have unstable angina, acute MI in a setting of left bundle and you're not able to read it off the EKG there anyway. So you have to proceed very, very thoroughly with a left bundle. It could be very, very conciliatory and people have had misgivings from that. So just be sure of, again, the history has to be acquired, whether there is any compliance, whether the patient has gone for revascularizations, whether the patient has had devices which have been interrogated, whether or not the current EKGs have changed from the previous ones, etc. So there's a whole bunch of issues that you have to really look at. And again, it's beyond the scope of the short video discussion that I'm giving you, but the whole idea of wanting to visit you on this video is so that you have an idea before you go and address that patient the next morning for a preoperative consultation, the fellow or whoever is screening that patient and presenting that patient for a perioperative event assessment. One has to look at all these parameters and factors before he or she can be classified as a low, intermediate, or high risk. Again, once again, I hope you enjoyed the discussion here and you learned something. Keep learning, keep teaching on MuniMeterHealth.com, your favorite website. And I thank you for your interest in watching on Facebook and YouTube. Those are our two channels, and we are constantly there for you. Please send us your comments. Please do like us if you will. We'll appreciate that. And also ask questions freely and suggest any particular subject that you would like me to present or discuss with you on MuniMeterHealth.com. I'll be very grateful if you write some comments and send us your like buttons, because that's very, very crucial and important for us. Then that means we have heard from you and we know that you have watched our videos as well. I thank you for your interest, and until then, so long. This is Dr. Jaitly from New York.